So, after doing the subjective evaluation, asking all those questions, then I turned to the dermatome chart. And these are on the internet. They're in every anatomy book. Find one you like. This particular one I wanted to show because it's color-coded. And you see the one on the picture on the left, the figure is facing you, and all of the colors are blue in the leg. When you look at the person from the back, you have reds. So the lumbar nerve roots supply sensory to the front of the leg, and the sacral segments supply sensory to the back of the leg and the back of the buttocks to the anus. So I'll show you why that is. The other thing I want you to note is that because I had a particular patient that came in complaining of right groin pain. Now, if you look at this chart, that would be the dermatome either for lumbar 1 or lumbar 2. She was getting injections in her lumbar spine at a pain clinic for L5S1. The pain didn't match up with the segment where she was getting an invasive procedure. I'll talk about that case later. So this is another illustration off the internet that shows, this is a pretty clear one, showing the anterior part of the leg and foot is our lumbar dermatomes, and the back of the leg, Achilles area, and part of the heel is sacral. Now, this makes it easier to visualize. If you imagine a person in this position, then you see where lumbar falls down and why the sacral's in the back part of the leg. So you need you need to map it out. You need a chart that you can draw in. So you want to ask your patient where they hurt, have them describe it, have them show you. If they have radicular pain down the leg, then show you how far down it goes and the path of it, and map it out. This will help you to see if this pain is coming from a particular dermatome, a particular nerve root, I should say. This is the chart that I use in my clinic. So I draw it out. This shows both legs, front and back, inside of the leg, different positions. And I draw it in. A patient may say, well, they have pain in their lumbar spine and down their buttocks on the left, but then the foot feels numb. So I color code it. I use red for pain and blue for numbness. This helps me zero in on a particular area of the spine. So what does this mapping out the pain and numbness on a dermatome do for us? Well, it tells us a lot. It tells us if a disc bulge is to the right or left of center. If all the symptoms are on the left, then the disc bulge is to the left of center. And here's another thing I've learned. The more pressure that disc is putting on the nerve root, the further down the leg the pain goes. Okay, so if the pain is going all the way to the foot, and you start treating a patient, and they come in one day and they say, well, I don't have any pain below my knee now. Guess what? They're better. There's less pressure on the nerve root. So more pressure on the nerve root, further down the leg. If somebody says, well, I don't hurt in my buttocks or down my leg, it's just in my low back, not as much pressure on the nerve root. If the pain goes far enough down the leg, you can trace it back to a very specific nerve root. If the pain's just in the low back, then you can't tell from that whether it's L4 or L5 or a specific nerve root. And like I said, it may tell you progress. If you start treating somebody and the pain is telescoping, it's coming up the leg towards the back, they're getting better. If you're treating somebody And they said, well, last week I only hurt my low back. Now it's down my buttocks down to my knee. You need to regroup. The patient's getting worse. So whatever you're doing is not working. I always ask the patient, just so I can have something to record as a progress, what was the worst pain you've had in the past week on a scale of 10? The least pain you've had. Because some people are in pain all of the time. They are never a 0. And then I ask them how much pain they have on that day. Now, a pain scale in research is considered ordinal data, and I used to teach research. It's not as specific as score data. Range of motion is score data. And ordinal data means if you got a pain scale of 0 to 10, the amount of pain between a 2 and a 3 is not exactly the same as maybe between a 9 and a 10. But a 10's worse than a 9. A 3's worse than a 2. It is not so specific, but it does give you information. And you can pretty much tell if somebody is getting better or not. So I'll be back with you for more things about the low back. The next section will be the objective evaluation, and that's going to be quite lengthy. So we will do that soon. This is Gloria Sanders again. I want to thank you for listening to my videos, and I invite your comments. All medicine should be a discussion. And that's how we get better at what we do. We need to be able to explain why we do what we do. There's no one way to do things. So I want to hear from you. I don't know what you're being taught in PT school now. So are your professors master clinicians? Maybe, maybe not. Have they seen patients in the last 15 years? Maybe, maybe not. So I want you to tell me what you're seeing, your new graduates. Tell me what you're seeing in your clinics. Tell me what you like about this. If you disagree with something, I want to hear it. And I'll get back with you. I want a lot of comments, and if I get them, I'll do a video of just responding to comments. Because I think medicine should be collaborative, and I think we need to share experiences. And I'm trying to do that with my experience, but I want to hear back from you. So subscribe, like, don't like. Let me hear from you.